Now you know the anatomy of tonsillar bed and also blood supply of tonsil. So what forms this peritonsillar space? That is this space filled with a loose areolar tissue bounded medially by the capsule of tonsil and laterally by superior constrictor muscle. Okay, this muscle, superior constrictor. So this lateral wall of peritonsillar space, this forms the medial wall of parapharyngeal space. Here comes the parapharyngeal space. Yet another important topic, clinically also comes along with the deep neck space infections. Parapharyngeal abscess is very common in your clinical practice. I will discuss on parapharyngeal space and parapharyngeal abscess after this. Okay. So this peritonsillar space is filled with a loose areolar tissue. That much you are thorough, isn't it? Now, peritonsillar, sometimes there can be collection of pus in this peritonsillar space. Okay, that is between this capsule of tonsil and the superior constrictor muscle. Here comes which fascia? Buccopharyngeal membrane. Okay, so between this, pus can be collected due to so many reasons, and that is called a peritonsillar abscess or a quinsy. Okay, peritonsillar abscess. So today's class is on peritonsillar abscess. It's very common in your emergency room. Okay, it's common abscess, peritonsillar abscess, or otherwise called quinsy. Why quinsy? Why it is called quinsy? Actually, this word originated from French, Old French. Okay, that was this was the Old French word meaning obsolete. Okay, from that it was got modified over time, and when the first E was gone, then S was also gone, and the word Quinsy came, and from that you got this English quinsy. Okay, anyway, that is peritonsillar abscess. So I already told you, for a short note, all these are needed. So definition of quinsy is collection of pus in this peritonsillar space, that is a space bounded medially by the capsule of tonsil and laterally by superior constrictor muscle, and this abscess collection usually occurs in this upper pole, this part. Okay, this area. So quinsy is defined as collection of pus in the peritonsillar space, usually in the upper part. Okay. Then what are the causes or etiology of this? So definition is over. Now etiology. One is a complication of after acute tonsillitis. Okay. That is, you know what is crypta magna, it was already described. So pus get collected, or infection first happens in this crypta magna, and later it gets collected there, it becomes an abscess, then it will burst into this peritonsillar space. Then it becomes a peritonsillar abscess. Second, it can be de novo. What is that? De novo is actually an Italian word meaning anew, from the beginning, that is without any reason it happens. So that is de novo. And third, it can be infection of the Weber's glands. What is Weber's glands? Weber's glands are minor salivary glands present in this peritonsillar or supratonsillar space. Especially, that is why this peritonsillar abscess is more common in the upper part of tonsil, upper pole. So Weber's glands are minor salivary glands present in the peritonsillar and supratonsillar space. Okay, so infection and abscess formation of these minor salivary glands, and this is more associated with there is a grade A evidence of smoking and periodontal infection. Smoking and dental infections, especially periodontal infections, has got a high association with this peritonsillar abscess. Oh, okay. So all these are the etiology or reasons for this. And as I already told you, it is a bacterial infection mainly caused by anaerobic organisms. Okay, anaerobes and also group A beta hemolytic streptococcus. Anaerobes and beta hemolytic streptococcus. It can also be caused by Staph aureus and also methicillin resistant Staph aureus, MRSA. So the main organism is group A beta hemolytic streptococcus, anaerobes, Staph aureus and also MRSA is got an association. Especially this MRSA is more commonly seen in patients having smoking and dental infections. Okay, so anaerobes and beta hemolytic, that is why the benzyl penicillin becomes a drug of choice. That I will discuss along with the treatment part. So now you know what is the definition of this and what are the etiologies. So think of pus getting collected in this space, especially towards upper pole. So that what will happen? This tonsil will be pushed medially, isn't it? Pus is getting collected in this. The tonsil will get pushed medially. Okay. And also this soft palate and uvula will become swollen and edematous, and also this uvula will be pushed towards the opposite side. Because pus is getting collected all over here, everything in this side will be pushed towards the opposite side. So as I already told you, this is usually unilateral, typically seen in young adults. And the contradiction with this is, I already told you in the etiology, this happens as a complication of acute tonsillitis. But acute tonsillitis is happening more commonly in children. But this quinsy is more common in young adult from 20 to 39 years. Okay. And then usually unilateral. It can also happen bilateral, and this bilateral quinsy is more commonly seen in patients having infectious mononucleosis. Okay. That is again an MCQ question. So bilateral quinsy is more common in patients of IMN, infectious mononucleosis. Okay. So unilateral quinsy. So what will be the complaints of the patient? Symptoms. The one is, this is not happening all of a sudden. So it is actually in progressive history, isn't it? So history of progressive, slowly progressive or a gradual progressive. What will be the first symptom? There will be sore throat. Okay, anything happening in the oropharynx, the first thing will be pain or sore throat. So there will be an history of progressive sore throat. Okay. Then after that what will happen? There will be, because this is swollen, that swallowing is not happening normally. So there will be pain on swallowing and also difficulty in swallowing. So painful swallowing, we call it as odonophagia. Okay. And then what happens? There comes difficulty in swallowing. So that becomes dysphagia. Dysphagia, first for solids, difficulty in eating solid foods, and eventually difficulty of swallowing the liquids also happen. So dysphagia, first for solid and later progressing to even to liquids. And then what will happen? I already told you there is a nerve in connection with the tonsillar bed. What is that? Yes, ninth nerve. Ninth cranial nerve. So what will happen? That glossopharyngeal nerve get irritated, so there will be referred otalgia. Okay, referred otalgia. I already took a class on referred otalgia. It's usually asked short note, and also most of the cases you will get referred otalgia clinically also. So go and refer that. So referred otalgia is yet another symptom. Then what will happen? There will be, because this jugulodigastric lymph node, tonsil lymph node draining is a jugulodigastric lymph node. Because there is jugulodigastric lymph node become tender and enlarged, there will be neck pain also, and there will be difficulty in moving the neck. Okay, that is called as torticollis. Okay, so neck pain. And also one more thing, because the patient or the patient cannot swallow, there will be drooling of saliva. Okay, drooling of saliva. So you can think about the etiology or the condition, and then you can tell the symptoms and also signs. Drooling of saliva. So these are the symptoms of the patient. Progressive history of sore throat, progressing to odenophagia, dysphagia, first for solid and then for liquids also, and referred otalgia, neck pain, and also drooling of saliva and difficulty in moving the neck. Okay, so these are the symptoms. And coming to the signs, what you get on examination, that you can tell from this picture. One is, if it is unilateral, usually it is unilateral, there will be congestion and of the tonsil with edema of the anterior pillar of the, this is anterior pillar, so there will be edema of the anterior pillar, edema of the soft palate, and this uvula will be edematous and pushed to the opposite side. So what are, on examination, what all things you will get? This one is a clinical picture of peritonsillar abscess or Quinsy on left side, right tonsil, below the posterior 1/3 of tongue, soft palate. See the edema of soft palate, and this one anterior pillar of left tonsil, and there is also edema of uvula, and uvula is pushed to the other side. Here this one right tonsil, so uvula is pushed to right side, and also you can see a portion of tonsils here. This tonsil is buried or gone behind the edematous anterior pillar and also the soft palate. Okay, this remember this picture. And also, as I already told you, there will be jugular-digastric lymph nodes will be enlarged and tender, so that patient will have difficulty in turning the mouth to neck towards the opposite side, presenting as torticollis. The patient will come like this. If the patient tries to move the neck to the opposite side, there will be pain. So neck will be flexed to the affected side. Okay, this side. So on examination, you can see congested tonsil with edema of the anterior pillar, soft palate, uvula with the uvula pushed to the opposite side, along with the enlarged and tender jugular-digastric lymph nodes, torticollis, and also this trismus, difficulty in opening the mouth. Okay. Now, what are the differential diagnosis? For anything, we can tell the broad classification can be due to infective etiology causes or other infective causes, inflammatory lesions, and also tumors. Okay, so the differential diagnosis of Quinsy, the headings can be inflammatory, infective, and tumors. Infective differential diagnosis, infective condition that can mimic a peritonsillar abscess. One is an peritonsillar cellulitis, the condition just preceding an abscess. It can present as a cellulitis. Then it can be a parapharyngeal abscess. Parapharyngeal space comes here, so a parapharyngeal abscess again can push the tonsil medially. Okay, so parapharyngeal abscess, then any dental abscess, and a coexisting infectious mononucleosis. So undergraduates, please note, even postgraduates, don't write these short forms like this in your exams or in Viva. Okay, you will be in trouble. Okay, so a peritonsillar cellulitis or a parapharyngeal abscess or a dental abscess or a coexisting infectious mononucleosis. Then inflammatory conditions which can mimic a peritonsillar abscess is, one is a Kawasaki disease. There is grade A evidence as a Kawasaki's disease mimicking an Quinsy. What is the treatment of Kawasaki's disease? That is aspirin along with an intravenous gamma globulins. Okay, so that is inflammatory. And tumors, you can again divide into vascular tumors, benign lesions, and neoplastic lesions. So the most common vascular tumors which mimic a Quinsy is a post-traumatic internal carotid artery pseudoaneurysm. Internal carotid artery pseudoaneurysm will be presenting exactly like a PTA. Peritonsillar abscess. It will push the soft palate as well. There will be a bulge of the soft palate, and sometimes it will push the uvula towards the opposite side. So what is the dangerous complication, catastrophic complication that can happen? If you directly go thinking that it is a peritonsillar abscess, if you are going and doing an incision and drainage, think of the condition. So that is why it is always advisable to do a fine needle wide bore aspiration, needle aspiration of this area before going to an incision drainage. Differential diagnosis is a post-traumatic internal carotid artery aneurysm, and then benign lesions like lymphoepitheliomatous cystic lesions in this area, then or it can be a neoplastic lesion. Neoplasms of which all area? It can be a tumor arising from the anterior pillar, or it can be tonsillar neoplasms like squamous cell carcinoma or lymphoma or a rhabdomyosarcoma. All these can be neoplastic tumors mimicking a peritonsillar abscess. Okay, so that is differential diagnosis. In the investigation, usually these clinical findings and the typical history are confirmatory. But if there is any doubt in diagnosis, you can go for one, as I already told you, a needle aspiration. It is always better to do a needle aspiration before going for an incision and drainage. Reason I already told you. And the pus, if you get a pus by doing an aspiration, it can be sent for culture and sensitivity so that you can start adequate or suitable antibiotic. And this pus should be sent for culture and sensitivity, especially in cases of resistant. If you think there is a resistant organism, your medicines are not, patient is not getting better even with your medicine, or in cases of immunocompromised patients, or if the patient is having a diabetes, and in also in cases of recurrent Quinsy, you have to send the pus for culture and sensitivity without failure. Okay, it is better to send pus for culture and sensitivity in all patients, but especially in cases of resistant organisms or in diabetic patient, immunocompromised patients, and also recurrent Quinsy. And if you suspect an IMN, you have to send the heterophil antibodies. Okay, in case of IMN, and also a complete blood count should be sent so that the total count will be elevated and the other parameters you can see, right? And if you CT scan, is it needed CT scan? In the differential diagnosis, I told so many other conditions. If you doubt any of that, you can go for CT scan. And also if you doubt any complications of this Quinsy, like a parapharyngeal abscess or a retropharyngeal abscess or a mediastinitis, you can very well go for a CT scan. And if you suspect mediastinitis, then you have to take a CT scan of neck along with the chest also. And MRI scan, if you suspect an internal carotid artery aneurysm or any other soft tissue lesions, you can also take an MRI scan of neck or along with or without chest. So usually the needle aspiration is the one which is needed in most of the cases. Okay, so that is all about investigation. And what about the treatment? I already told you it is mainly caused by anaerobes and group A beta hemolytic streptococcus. So what is the drug of choice? Intravenous benzyl penicillin is the drug of choice. So if the patient is sitting in front of you, directly the first thing you have to do is admit the patient, because there is difficulty in swallowing, there can be electrolyte imbalance, there can be fluid imbalance. So better hospitalize the patient and start off an IV cannula. Then start on intravenous benzyl penicillin, and if the patient is sensitive to benzyl penicillin, you can go for erythromycin. And adequate fluid and electrolyte imbalance correction has to be done. And along with that, the supportive measures. If the patient is having pain, give analgesics. If there is fever, give antipyretic. And you can also give a single dose of steroids so that the edema and inflammation will be reduced. And the patient, after putting an incision and drainage, the patient will be able to open the mouth and also can take fluids. Okay, so the treatment first is hospitalization, then correction of fluid and electrolyte imbalance, then start on IV benzyl penicillin. I am writing short forms, don't do that. Benzyl penicillin, along with the supportive management, that is analgesics and antipyretics, then a single dose of steroids. Single dose is enough. Don't give steroids for a long time. Okay, single dose of steroid is enough because it will give an excellent improvement in case of mouth opening and also swallowing. Okay, and if the patient is not responding with this, you can go for surgical measures. What is that? Do an incision and drainage. Any abscess, treatment is IND, incision and drainage. So here also, with medical measures, patient is not improving, you can go for an incision and drainage. So there are indications for incision and drainage of abscess. Indications for incision and drainage of Quinsy is, one, obviously if the pus is pointing, like in this, see, pus is pointing here. So one is pus pointing abscess. Okay, you can do an incision and drainage. And other conditions, even if there is no pus pointing, the patient is not responding to an IV antibiotic, no response to medicine, or the patient's condition is deteriorating. Okay, condition deteriorating. Even after you are giving IV antibiotic according to cultural sensitivity, even then the patient is deteriorating, go for an incision and drainage. Or if you are doing some other imaging modality and you found pus in this peritonsillar space. Okay, found out pus in peritonsillar space by imaging modality, then also you can go for an incision and drainage. So the question is, where will you put the incision? That is, there are 2 points. One, you can very well put on the point of maximum bulge. If here is a maximum bulge, you can put a incision over there. Or another point is usually asked in Viva, and you have to stick on to this if you are doing this in clinical setting also. You have to draw 2 lines, imaginary line, one passing through, this is uvula, so one line passing through base of uvula like this, and another line passing through anterior pillar. Here this is the anterior pillar, so through the anterior pillar. So the point here, the 2 lines are intersecting here, and point just lateral to this, you put the incision. So it comes here. See, one line passing through base of uvula and second line passing through perpendicular line or vertical line passing through your anterior pillar, and point just lateral to the point of intersection of these 2 lines here. Here you can put the incision. Okay, usually we use Quinsy forceps. Picture of Thelenius Quinsy draining forceps. You can see note the tip of the forceps. There is a guard so that you will not push deep into the tissue. So extra injury of the tissue will not happen. With this, we do the incision and drainage of Quinsy. Patient is usually in sitting position, or the dental chair. The position in dental chair is the best one. And this area can be, whole area can be anesthetized using 10% lock sprays. There is no need to put injections into this area. And after that, depress the tongue, and you can put the incision either at the point of maximum bulge like this, or this is base of uvula. So one line passing through base of uvula and another one passing through this anterior pillar, and at the point of intersection of this 2 line, just lateral to that, put the incision and take a sinus forceps or artery forceps and poke into the incision and open it in either direction. So ideally you have to put a cruciate incision so that it will not, it just will not approximate too soon, and the drainage of the abscess will be complete. And after opening and the abscess, ask the patient to spit into a kidney tray or a bucket or whatever it is. So the sitting posture, if the patient is in sitting position, it will be easy. Okay. So this is how you do a incision and drainage of Quinsy. And before that, never forget to do a needle aspiration of this pus. And after doing an incision and drainage of Quinsy, in order to avoid recurrence, it is better to do a tonsillectomy 4 to 6 weeks after an attack of Quinsy. So that is called an interval tonsillectomy. That is, we are doing an elective tonsillectomy 4 to 6 weeks after an attack of Quinsy. And another term you have to remember is an hot or an abscess tonsillectomy. What is this? Hot or an abscess tonsillectomy. This is doing removing the tonsil along with an abscess drainage. That is doing tonsillectomy at the time of an attack of Quinsy. You must have remembered that an absolute contraindication for tonsillectomy is active infection. So imagine what will happen if you do a tonsillectomy at the time of Quinsy. There will be excessive bleeding and anesthesia complications will be there. Chance of aspiration is there. Everything is there. So anyway, there is a method of tonsillectomy which is called hot or abscess tonsillectomy, and there are so many controversies going on regarding this hot and abscess tonsillectomy, whether to do or not to do. Okay, forget that and just remember there is an interval tonsillectomy done after 4 to 6 weeks after a drainage of abscess in PTA, and hot or abscess tonsillectomy done at the time of drainage of an abscess of Quinsy. Okay, and that is treatment. So medical treatment, first hospitalize the patient and IV antibiotics, analgesics, antipyretics, along with that give a single dose of intravenous steroids, and treatment, correction of fluid and electrolyte imbalance if any, adequate hydration, and then if I have already told you 4 indications for incision and drainage. If that indications are present, go with an incision and drainage of abscess at the site, one at the point of maximum bulge or at the point of a straight line passing through base of uvula and a vertical line through anterior pillar, a point just lateral to that. And before doing an incision drainage, always go for a needle aspiration. Okay, why I already told. Then next is complications. What all complications can happen? One thing, if there is an abscess, it is bulging filled with pus, suddenly it ruptures. So what will happen? Chance of aspiration is there, and all the complications, lung complication associated with an aspiration. Okay, so one is rupture of abscess leading to all other complications, and second one, there is chance of airway obstruction. If it is causing rupture or severe edema, can go for an airway block, airway obstruction. In that case, you have to manage the airway either by tracheostomy or endotracheal intubation, whatever it is. Okay. And the third, what will happen? I already told you which space is here. Parapharyngeal space. So there is chance of a parapharyngeal abscess. Okay. And from the parapharyngeal, it can go to retropharyngeal abscess also. And then if it is going down, there is chance of mediastinitis. Okay. Mediastinitis, another complication. Then necrotizing fasciitis is also a complication of Quinsy. Necrotizing fasciitis. Okay. So rupture, airway block, parapharyngeal abscess, mediastinitis and necrotizing fasciitis are the common complications of Quinsy. Okay, so this is all about Quinsy. Remember that and study.